we're going to see Lou Gehrig's disease. This is also called amyotrophic lateral sclerosis. Here, the patient will have troubles or let's say signs of upper motor neuron lesions and lower motor neuron. So if we put the schematic representation of the spinal cord, here we have the posterior cords, posterior cords. There will be damage to the ventral corticospinal tract and the lateral corticospinal tract. So the lateral corticospinal tract would be here. Here the ventral would be around here. But also, you know, we are damaging at the level of this spinal cord, we are damaging the bodies of the neurons, of the alpha motor neurons. And we are damaging this tract, that is for which the upper motor neuron is coming down, thing like this. So the patient can have, because of this, the lower motor neuron, yes, the patient will have weakness on the extremity, on the limbs, could be more of lower motor neuron or upper motor neuron, depending on which limb. But also, not only here, we are also damaging the corticobulbar tract, not only the pyramidal tract. So it's kind of the same thing, upper motor neuron, lower motor neuron, but now of the cranial nerves involvement. Remember that the cranial nerve, in this part that we care about, the motor part, cranial nerve would be just this. This is the peripheral nerve. In the pons, for example, here, we will have, this would be the cranial nerve nucleus, like this. This would be the lower motor neuron and would present with bulbar palsy. But if we damage the upper motor neuron here of the corticobulbar tract, the patient would present with pseudobulbar palsy. So this pseudobulbar palsy, actually, it is the supranuclear palsy, and this would present with dysarthria, dysphagia, increasing on the jerk of, let's say, gag reflex and yaw reflex. The patient would present with this. So if we have motor involvement, because this is only a motor problem, motor involvement of cranial nerves, let's say 5 could be 9, 10, etc. This means that the damage is also above the foramen magnum, not only on the spinal cord. So this is very important, very useful for the differential diagnosis of cervical myelitis or other spine cord diseases. Here we could see on the histopathology of a neuron that is damaged. We could see Bumina bodies. These are autophage vacuoles. And we see, let's say, some damaged proteins that are marked with ubiquitin. So these are called angular fibers, and the angular fibers is the atrophy of the muscle. And we would see the accumulation of misfolded proteins that would be seen as PAS positive. Remember that PAS is sensitive to protein, that is, it stains protein. Now, the primary lateral sclerosis usually only affects the lower extremities, and the treatment is sometimes the patient can have respiratory failure. So in that case, the first step will be a non-invasive positive ventilator, mechanical ventilator. The patient could have spasticity, and sometimes the spasticity could be painful sometimes. But to treat this spasticity, we can give baclofen, for example. Now, the treatment for amyotrophic lateral sclerosis, this treatment is Riluzole. Here we are blocking the sodium channels of the damaged neurons, and at doing this we are decreasing the glutamate excitotoxicity. And also here we are decreasing the progression of the disease at blocking these sodium channels. So the presentation of this is usually could be not only motor but also involvement of the corticobulbar tract and the spinal pyramidal tract. And this would aid on the diagnosis or differential diagnosis of just spinal cord lesions.